Hello, I'm Professor Michael Wang from the University of Leicester in England, and today I'm going to be talking about the psychological impact and responses to the current coronavirus pandemic that is affecting us all. I'm going to be drawing on my own experience, first of all, in recently organising psychological support systems for frontline staff in ICUs and elsewhere in the healthcare system in England. And also I'm going to be drawing upon my own personal experience of being in an ICU 7.5 years ago. And some of you may remember that I gave a presentation on that experience at a previous InPACT conference. My talk has 4 components. The first section deals with the psychological difficulties that we're now seeing in the general population and how psychologists might help to remediate and prevent some of those difficulties. The second section concerns difficulties for those with existing mental health problems and how we might help them too. The third section refers to specific difficulties for those admitted to hospital and the intensive care unit, what they are and how psychologists might help those particular difficulties. And the final section is about the difficulties encountered by frontline healthcare staff, including ICU staff, and again, how psychologists might be able to help remediate those difficulties. As if you didn't need reminding, this slide simply illustrates the extent of the crisis and the number of countries, which is almost everyone, that are involved. Most of us are also experiencing some degree of lockdown, and our governments are wisely requiring us to stay at home. This has resulted in momentous change in people's behaviours and habits, and as we see here, major tourist attractions are now almost deserted. Here we see Trafalgar Square in the centre of London, which highly unusually is almost depleted of people. And of course we are all expected to keep our distance even from close friends and loved ones, so as not to enable the virus to transfer. And this is a brand new experience for most of us, having to curtail intimate contact with those we love. Something as mundane as going shopping has become a rather bizarre experience of spacing out and observing the social distancing rules. Perhaps more importantly, from an emotional and psychological point of view, when we lose loved ones at the present time, not only are we not allowed to spend the final moments with those people, but when it comes to the funeral itself, we are very limited in the numbers who can come and say goodbye to those people. It is also very apparent to us all the extent to which our economies are being impacted by the shutdown and the effects of the virus. So this slide summarizes some of the major difficulties that the general population are experiencing right now because of the crisis. First of all, many of us are experiencing anxiety. Anxiety about becoming infected ourselves, and then anxiety about infecting vulnerable loved ones who ultimately might die as a result of that same infection. And then we have the fear of death, not only the fear of our own death as a result of being infected, but the possibility of losing loved ones because of the virus. As already mentioned, we've also got the additional concerns about the economy and our own personal situation financially, with worries about income, future job security, and perhaps mounting debt. In addition to all of this, we've got constraints on our physical and social activity, which we know that these things are really important for maintaining mental health. Moreover, we have constraints on face-to-face communication, and importantly, the giving and receiving of physical affection as far as those who don't actually live with us are concerned. And again, we know that this is really important in terms of maintaining mental health. In addition to this, because of the present limitations on activity, and particularly work-related activity, there are clear constraints on us achieving our life goals. Taken all together, we can expect a major impact on mental health in the population. So, in the face of these difficulties, what can psychologists do to mitigate these difficulties? Well, first of all, we can take political action. We can offer expert advice to local and national decision makers depending upon our platforms of influence. We can take community action at local level. We can encourage community groups, online support, activity and interest groups, and indeed we can start these groups up ourselves. We can provide psychological self-care advice through community contacts, YouTube videos and social media, etc. It's really important that we emphasize alternative interpersonal communication other than face-to-face contact. For example, using the telephone regularly, contacting relatives and friends, using social media and online video platforms to communicate. It's also really helpful to encourage people to have regular exercise and to have a regular pattern to their lives despite the current abnormal situation and lockdown. I'm now going to turn to the second group of people, which is people with existing mental health problems. And these include people who have previously been experiencing obsessional compulsive disorder, and they will probably have many of their compulsions worsened, and particularly those who are concerned about contamination. And unfortunately, the nature of this crisis means that their overvalued ideas concerning germs and contamination will be inflated. And then we have people who've always been worried about their health, and they're going to massively increase their anxiety and vigilance with regard to being infected. And they're going to be overly vigilant about noticing signs that they have the virus. And then we have people with paranoid psychosis who have delusions concerning conspiracy theories, and that perhaps, for example, that someone has contaminated the water supply, and they will have all sorts of ideas, probably incorrect, about where the virus is coming from and what they need to do to avoid it. And then, of course, we will have increasing levels of depression because of the interference with social life and positive activity, particularly physical activity. In the midst of all this, we have, as a result of the crisis, a reduction in mental health services, often due to redeployment of mental health staff to be involved in frontline activity dealing with the physical disease itself. And also, psychiatric inpatient facilities are often being turned into COVID-19 wards to cope with the pandemic. And finally, there is reduced access to mental health services because people are worried about catching the virus if they go into a hospital or a unit. So all of the factors on the previous slide may lead us to conclude that we are in for a nightmare, a tsunami of serious mental health difficulties in the population, which are just going to get worse and worse. But before we draw that conclusion, we need to remember that there is evidence of reduction in mental health problems during times of national crisis, such as wars. But before we're too drawn into that, we do need to remember that the circumstances of the current crisis are somewhat different to that of a war or a national conflict, particularly because of the way in which we're having our possibility of social interaction being constrained and limited so that the virus isn't spread. So one of the principal sources of psychological support is being undermined by the lockdown. And so we might not see such a reduction in psychological problems. Also in wartime, there is normally a reduction in the suicide rate. But again, because of the lockdown, we might still see people taking their own lives in isolation. Having said all of that, I have had some anecdotal reports within English mental health services of a reduction in patients, and particularly I'm thinking about psychological therapy services, but this may be because people are not coming forward to services because of fear of becoming infected with COVID-19. Some of this does have relevance to Maslow's hierarchy of needs, in that it's possible that people are reviewing their situation as being much more about basic physical requirements, such as the need for being able to eat, having the security of the home, and not being in physical danger, and that those basic needs are overshadowing any psychological needs. So in terms of what we as psychologists might be able to do about the aforementioned problems in mental health, this slide summarizes some of the things that we've been doing in England to try and counter those pressures. So first of all, we've had a public statement from the National Health Service in England to resist pressure to divert and redeploy services and workforce to frontline COVID-19, and to ensure that mental health services continue as they were before the crisis. We're also encouraging the general public to access existing mental health and counselling services if they're aware of a problem, and also to provide online self-help packages for anxiety, insomnia, depression, for example. We're also providing basic telephone counselling for people in need. But perhaps very important is that we need to say to people that given the current circumstances, it is perfectly normal to feel anxious. And this is not some psychopathological problem that they are experiencing, and that much of the population is experiencing the same thing. This slide just simply is reminding us that With the experience of previous crises and emergencies, what we're experiencing at the moment may represent just the first wave of a triphasic situation in which there is more immediate mortality and morbidity from the virus that we're all well aware of and which is on our televisions every evening. But then there is a second wave where we start to realize the impact of the services being diverted towards treating the virus itself, but ignoring or not neglecting other conditions. So there's a second wave of those particular conditions coming on board, such as heart disease and cancer. And then we've got a third wave where we've got people with long-term conditions having had their care interrupted and starting to need extra emergency care. In the midst of all this, we have, of course, the emergence of mental health and psychological difficulties which are arising as a result of the crisis. And as you see, that there is a delay from the initial acute phase of the crisis to the emergence of the mental health and psychological problem. I now want to talk about the group of people who are really at the sharp end of this crisis, and they're the people who, having been infected, have to be hospitalized and may indeed have to go into intensive care. This is usually because of breathing difficulties. We think that this is less than 10% of all the people infected. It's very difficult to know the exact figure because we don't have exact figures for the numbers who are infected unless you happen to be in a country where there's been very rigorous testing. There are many people who have so mild effects from the virus that they don't even know they've had the infection. So just a warning about the use of these statistics. We do know, however, that a significant group of people do end up in hospital, and of those, about 15% require mechanical ventilation. What does that mean? It means that these people are in need of such support for their breathing that they have to be given a paralyzing drug. They have a tube down their throat and a machine actually breathes for them. It pushes air into their chest, very much like what happens in an operating theatre when you're having an operation under paralysis. Of this 15% of people, about half will probably not make it, unfortunately. They will die. So it's appropriate that we have the greatest concern for these people, not just because of the high death rate, but also because they have the highest rates of psychological problems after discharge. Now, in addition to mechanical ventilation, there are two other ways of assisting with breathing in hospital, and one is known as continuous positive airway pressure, or CPAP, and some of you will have come across this in relation to sleep apnea. So people who have this condition where their airways close when they're asleep and their tissues in their throat relax and obstruct the airway, and this can be helped with a machine that blows or pushes air into the lungs. So that's called CPAP. It's not the same as mechanical ventilation and is less invasive. Something though that is even more invasive is known as extracorporeal membrane oxygenation, or ECMO, and only specialized units can offer this. And this is where a machine outside of the body oxygenates the blood, and then the blood is returned into the body. So it's very similar to a heart-lung machine but it essentially oxygenates the blood without putting any effort into the lungs. We know that that particular form of procedure also carries with it a high rate of psychological difficulty, and I'll be talking about that later. We also know that there's a whole series of comorbid diseases which makes the outcome of the infection worse. And I'm thinking here about cardiovascular disease, diabetes, COPD, asthma, and hypertension. These things may be associated with a higher risk of death, and also frail patients. It's not just the elderly. There are some elderly people who are very fit, and they will tend to do okay. As far as people having been through these experiences in intensive care and been discharged, we know that there are high rates of psychological problems. So between a quarter and a third of all ICU people admitted will go on to suffer from post-traumatic stress disorder after discharge. We now know that there are even higher rates of post-traumatic stress disorder in people undergoing ECMO, and it could be as much as a third of that group. Another problem is delirium, and we know that between 45% and 87%, depending on the study, of ICU admissions encounter delirium, usually in the form of hallucinations, but also delusions as well about their predicament. Often these hallucinations and delusions are paranoid. So, for example, it's quite common to come across people who believe that the ICU medical and nursing staff are up to no good, and that their objective is to torture or kill patients. Thankfully, almost all of these ideas will disappear after discharge. We do know that delirium is higher with mechanical ventilation, and we also know that delirium is associated with post-traumatic stress disorder. In other words, delirium predicts people are more likely to have post-traumatic stress disorder. And the interesting thing about this is that what has been found is that it is the delusional ideas and hallucinatory experiences which are more commonly the content of flashback and nightmare experiences that form the post-traumatic stress disorder. And interestingly, if people have real and accurate memories of their time in ICU, very often this is protective against post-traumatic stress disorder. It's really important to note that mechanical ventilation requires paralysis, and in order to cope with that experience, people are heavily sedated. This does not necessarily mean they are completely unconscious. And what we know is with benzodiazepine sedation, which it often is, there is also the risk of implicit emotional memory. In other words, it's possible for people to have distressing experiences for which they have no conscious or explicit recall afterwards, but those emotional difficulties will emerge nevertheless in their day-to-day life. Now, this is a rather complicated slide which concerns the factors and origins of post-traumatic stress disorder following ICU stay. The top third or top half of this slide concerns factors which have been demonstrated to increase the risks of PTSD, and across the middle are the states that we think also are associated with the generation of PTSD. So we've got preserved implicit memory or emotional memory of the kind that I was just talking about. And then we've got impaired consciousness on the right. What mediates these two states is the use of benzodiazepines and also opioids like morphine. So the slide really is a proposed model as to how we end up with higher levels of post-traumatic stress disorder in the ICU population. So what psychological care can be offered to these people coming out of the ICU with things like post-traumatic stress disorder? Well, the first thing to say is that for many, these problems will evaporate on their own. They will spontaneously remit, but it's really important to monitor people just to make sure that there aren't problems persisting. So especially during the first few days and weeks, people need to be reviewed regularly to ensure that there aren't psychological problems persisting. In my experience, it's really important to spend time with the patient talking about the causes of what they experienced and to try and make sense of it. Quite often there are misconceptions and misunderstandings about what went on in the ICU, and people will not understand necessarily that they have had a muscle relaxant, a paralyzing agent, which has prevented them from moving. And they may well have developed ideas, sometimes delusional ideas, about what staff have been doing. If people show evidence of post-traumatic stress disorder in terms of flashbacks and nightmares, and that these are persistent, then specific treatments will need to be organized. And in particular, I would recommend, as does NICE, that's the British body that recommends treatment on the basis of empirical evidence, that NICE recommends trauma-focused cognitive behavior therapy in particular. What does that mean? It means focus on the actual trauma itself, and in particular the content of the flashback. This takes a degree of skill and evaluation because often it's issues that are underlying the content of the flashback that need to be addressed. And very often one is asking the question, so what? What comes next in the flashback content? And it then requires specific and repeated exposure to the thoughts that underlie the flashback content. With eye movement desensitization and reprocessing, which is another recommended treatment, again, what happens here is that one is getting patients to move their eyes rhythmically from one side to the other, or it could be using hand movements. And whilst this is going on, there is a focus again on the trauma itself and the content of flashbacks in order to encourage desensitization and reprocessing. Now, in the final section of my talk, I want to talk about the experiences and difficulties encountered by frontline staff, and in particular in this case, ICU medical and nursing staff and paramedical staff. You will know that frontline staff urgently require personal protective equipment, or PPE, and in many places there are shortages of this equipment. But something else you need to know about it is that it is very uncomfortable, it is hot, and the attachments, the wrappings, the straps can cause bruising and sores. So this slide summarizes the psychological challenges for ICU staff. We've already touched on PPE, and the discomfort that's associated with wearing it. But something else that is equally important is the impairment of communication. It is very difficult to speak in an understandable way, not only to colleagues but also to patients themselves. We've also mentioned that there are PPE shortages, and consequently many staff fear having become infected themselves, and there is indication that frontline staff, especially ICU staff, may be more vulnerable to a more serious illness if they get it, and even death. And this seems to be a function of what's known as viral load. This is about how much virus is being exposed to. And it seems that because frontline staff stand a chance of being exposed to greater amounts of virus, that this then results in a worse illness. Then, of course, there's a fear of taking the infection home with you and passing it on to loved ones at home. There are also many frontline staff who are now living on their own and isolating themselves from their families because they are so fearful of contaminating people at home. Most ICU staff are used to death and dying. They're probably used to having at least one death a week in a typical ICU setting, but they're not used to having more than one death a day, which is the current typical situation. So this is just a huge trauma affecting them, because you get to know the patient over a couple of weeks and then they die, and you're often the only human contact at the time the patient dies. Another problem is staff shortages because of isolation of colleagues who have had symptoms. So not only is there an issue about ICU staff in general in terms of staffing, but for all of the staff available, some will be off ill because they can't risk bringing the infection into the unit. And the final point on this slide is that of moral injury, and I'm going to expand that in the next slide. So the concept of moral injury is where a clinician or nurse is forced to make a decision, a clinical decision, against their values, ethics, and morals. So, for example, it may be that because of excess demand over resources, you have to make the decision that you can't put a patient onto a ventilator, even though you know that the ventilator might very well save their life, simply because you haven't got enough ventilators or critical care beds. This kind of situation causes intense feelings of shame, guilt, and disgust, and also anger, often anger with people in authority that they are forcing you into this situation. And these circumstances can lead to low self-esteem, depression, and even suicide. I'm very grateful to my colleague, Dr. Sonia Wallbank, for this particular slide. Sonia is the national clinical lead for the COVID-19 response in terms of psychological support for staff in England. And you will see in this slide that there are 3 phases. In the first phase, there is preparation. So we know that the virus is coming and preparations are being made. And at the present time, we're probably in the active phase, when we've got quite high workloads happening and people having difficulty coping with the demand. But there is then going to be a recovery phase, and you'll probably notice by reading through this final column that the psychological difficulties may be more intense in the recovery phase, when things in terms of the physical demand, healthcare demand, are declining. This is another slide which represents the pattern of difficulties over a period of time, and to show that this is cyclic. So it isn't just one single crisis and then it's over. It's likely that we're going to see re-emergence of the virus and peaks of activity over the next coming months, and that they include their own periods of psychological difficulty. And this slide illustrates what we have been doing in England to prepare for assisting, supporting frontline staff. And you'll see that it's using this acronym CARE, C-A-R-E, and this represents progressively increased levels of intervention and support for frontline staff. And I'm not going to go through the whole slide. I'm going to leave it for you to read through it. So this slide finally summarizes the support that we've been developing for ICU staff. In the first instance, we're providing online self-help packages for anxiety, insomnia, and depression. So these are very much computerized self-help that people can use in their own time without necessarily having to self-identify their need for support. And then in the next level, we have some basic telephone counselling where people have opportunity to tell someone confidentially what the difficulties are for them. We also are running webinars which encourage emotional expression and discussion amongst groups of people about the difficulties they're experiencing. And then we also have facilitated small group Zoom support for groups of clinicians. In the final phase, we are offering one-to-one sessions with a clinical psychologist for those who need it. And this may be up to 6 sessions. And we are expecting to encounter common mental health problems like anxiety and depression, as well as post-traumatic stress disorder. And these interventions will be brief, evidence-based treatments. We've now reached the end of my presentation. I hope you've enjoyed it and it has been suitably educational. I wish you all the best and hope that you will keep safe and well.